Hello, everyone. My name is Kim Brawley, and I'm a private practice dietitian specialized in IBD nutrition. Thank you, IBD Club, for the invitation to share this article on avoidant restrictive food intake disorder in patients with IBD. To provide a little bit of background, Arfid is a diagnosis that's applicable to individuals of all ages whose behaviors lead to insufficient caloric and/or nutrient intake, and it causes at least one of the following burdens. There are three categories that can lead to Arfid symptoms: avoidance of many foods, low appetite or limited interest in eating, and a fear of negative consequences after eating. Patients with IBD are at high risk for development of disordered eating patterns due to a heightened focus on weight, adverse GI symptoms and inflammation, dietary restrictions, and lack of multidisciplinary team support surrounding these topics. Prevalence of Arfid is 12 to 21% in patients with GI disorders, and 16 to 68% of patients with IBD are malnourished. There's a lack of research looking at Arfid risk and the risk of malnutrition. Our study today was published in the Journal of Clinical Gastroenterology and Hepatology, August of this year, with three aims: to estimate the prevalence of Arfid, evaluate the risk factors for Arfid, and to examine the relationship between Arfid risk and malnutrition risk. This was a cross-sectional study of 161 adult patients who completed surveys after clinic visits, capturing eating behaviors and nutritional status. Data were taken from the electronic medical records, looking at these aspects. And the presence of active IBD-related symptoms was defined as having a Harvey-Bradshaw index greater than 4 for Crohn's disease, a clinical colitis activity index greater than 2 for ulcerative colitis. An active inflammation was defined by a CRP greater or equal to 5, a calprotectin greater or equal to 250, or colonoscopy findings of inflammation. Arfid risk was measured using a 9-item avoidant restrictive food intake disorder screen, and a total threshold of 24 was used to identify patients at Arfid risk. Additional survey questions captured food groups that were avoided during a flare and during remission. Malnutrition risk was measured using an adapted patient-generated subjective global assessment form, and this was based on self-reported criteria, capturing 4 sections: weight change, changes in food intake, symptoms, and nutrition impact, and activities and functions. The study showed that patients widely reported avoiding lactose, spicy foods, alcohol, wheat products, deep fried or fatty foods, and caffeine, and these avoidances were widely prevalent regardless of active symptoms. 68% of patients did not report IBD-related symptoms, while 24.8% had active symptoms. 92% of 161 patients reported avoiding one or more foods in the presence of symptoms, and 75% continued to avoid one or more foods in the absence of symptoms. A positive Arfid risk score greater or equal to 24 was present in 17% of participants. And of those 3 categories associated with Arfid, patients reported the greatest reason for avoiding foods was a fear of a negative consequence after eating them. Active symptoms and inflammation were significantly associated with a positive Arfid risk. 29% of 133 patients scored for malnutrition risk, and patients with a positive Arfid risk screen were significantly more likely to be at risk for malnutrition. Strengths of the study include that the topic is relatively unexplored in IBD population. The study suggests association between Arfid risk and malnutrition risk. It evaluates the prevalence of Arfid in an adult IBD population, and it was a good use of surveys to capture an association. Limitations include the study design and a small sample size, an inability to piece out symptoms related to IBD versus potential IBS. The surveys did not enable a diagnosis of Arfid or malnutrition, and the foods avoided, in my mind, were not nutritionally significant. In conclusion, the study supports that Arfid eating behaviors are common among patients with IBD, furthering their malnutrition risk. Researchers recommended consider screening patients with active IBD symptoms for Arfid risk, and then referring to a registered dietitian. I would also add a referral to a mental health provider for counseling around this. As always, more research is needed, especially a study looking at the diagnosis of Arfid and malnutrition to assess the prevalence amongst IBD patients. Thank you so much for your time, and I look forward to hearing your thoughts on the topic.